respected delegates. Professor Monica Lakhanpaul, Professor of Integrated Community Child Health, University College London, is presenting on behalf of CHIP Consortium, which is One Health Citizen Science approach to reduce the infection burden and antimicrobial resistance in under 5 years in peri-urban slum in low and middle income countries. Professor Lakhanpaul graduated from medicine in 1992. She trained as clinical doctor in pediatrics and gained her academic doctorate in pediatrics and child health in 2003. In 2012, she was appointed as Professor of Integrated Community Child Health at UCL GIS Institute of Child Health UK. In 2016, she was appointed Head of the Population Policy and Practice Department. She holds a number of leadership positions and is most recognized for being the first appointed clinical director leading development of national guidelines for children in the UK for the National Institute of Care and Clinical Excellence. Receiving the Asian Woman of Achievement Award in 2012 and is currently Provost for South Asia at UCL. She is also adjunct professor at Public Health Foundation India and co-director for the CHIP. Her research programs aims to take cross-sector, multidisciplinary, structured and collaborative approach to improving the outcome for children and transform service for patients. Her research particularly uses community participatory and citizen science approaches to translate evidence into community-based interventions to promote implementation into clinical practice and health policy. Her research focuses on inequalities in health, inclusion health, co-designing cross-sector solutions with health, education, creative arts, engineering, and environment to minimize impact of infection and malnutrition on child health outcome and their families. Thank you.
Thank you, Dr. Justin. Now we move on to the session, Impact of Zoonotic Infection on Children. Now I invite co-chair of the session, Dr. Asha Antony, Instructor, Veterinary Medicine, College of Food and Agriculture, UAE University, for few words.
Am I audible?
Yes. Yes,
thank you, Dr. Rishad. Honorable Vice Chancellor, Dr. M.R. Shashindranath, sir. My most reverend teachers, Sunil sir, Maya madam, Usha P.T.A. madam, and all other teachers, delegates, and participants present here. Good afternoon, everyone. I am Asha, joining you from Alain, UAE, and I am very glad to see that we are about to hear a very interesting topic from eminent researcher and scientist, Dr. Monica Lakhanpaul. She has done quite a lot of research in public health, in zoonosis, in pediatrics. I'm looking forward to hear from you, Dr. Monica. Thank you for being here. Thank you.
Thank you, madam. Now I invite Professor Dr. Usha P.T.A. madam, chair of the session, to address the gathering, and also I am handing over the session to Dr. Usha P.T.A.
And this session on this impact of zoonotic infections on children, and I'm very grateful to Dr. Maya and other IVA dignitaries for giving me a chance to be a part of this particular session, because I think this is a very new topic for me. That is, it is an impact of zoonotic infection on children. So it is it will be very interesting. And with great pleasure, I welcome today's speaker, Dr. Monica Lakhanpaul, to this session, and also invite her to present the topic on impact of zoonotic infection on children. Dr. Monica Lakhanpaul, please present the topic.
Okay, sorry, because I can't see from this side. So sorry everybody for that delay in the slides. It's technology as we know it. We try very hard with technology, but sometimes it doesn't work. So I'd like to just thank everybody for inviting me here for this presentation. And if for some reason the slides don't come through, please do let me know so that I know if we're keeping up with each other or not. But I'd like to thank the organising team and Dr. Prajit and Dr. Maya and your Vice Chancellor and all of you really for inviting me for this auspicious occasion. And coming at the end of this whole day, I'm sure everybody's quite exhausted. And you've also had a lot of data. I've been listening to some extremely exciting and interesting presentations from previous speakers. I'm obviously not an expert in veterinary science. I'm a paediatrician. So I'm really giving this presentation from a different perspective, from my own perspective, which is someone who sees children every day, considers their lives and their pathways of their lives ahead, and what are some of the complexities around how children interact with the livestock around the environment they're in, and what we can do to improve their outcomes. So who am I? You've heard a little bit about who I am, but why am I showing this? On the left-hand side, you can see me as a young child who was in India, having my own nits taken out of my hair. And I clearly remember my father taking me to the buffaloes and taking milk directly from the animals. And this is something that was very exciting at the time, but the dangers of it I didn't actually realise at the time. In addition to that, I don't know how many of you have heard of Leicester in England, but Leicester is one of the first cities that have been locked down again in the UK. And some people have wondered why this is. And it comes really to where my heart lies with all the research that I do. One aspect of the work that I do is around behavioural science, understanding why people do what they do. And one of the reasons that Leicester was locked down post-COVID, being the first town in the country to have done this, is because really nobody took a bottom-up approach to think about how the community lives within Leicester. Where do we live? How do we live? Do we live in extended families? It's a very high ethnic minority country, very diverse community that we live in. People do live in very crowded conditions, often sharing beds to go because they work in factories. And the children in the UK have been told that they are at the lowest risk of carrying COVID and the severity of their condition is the least. Unfortunately, children can still carry COVID and give it to their grandmothers and grandfathers, but nobody really thought of this. So a one-size-fits-all did not work in this One Health approach to COVID in the city where I currently live. So I have my own lived experiences of what it has been like. Before I go on, I want to thank all of you first for inviting me, but also some of my colleagues, as listed here, who've helped me with these slides, and also all members of the consortium on behalf of who I'm talking. So as mentioned, I'm here on behalf of the CHIP Consortium, and the CHIP Consortium stands for Childhood Infection and Pollution Consortium. And you'll see a lot of names at the bottom there from across the world who've come together to really try and think about, as I mentioned, the complexities around child health and the impact of living in an environment where we're constantly interacting with animals and what impact that has on long term for these children. So this is the consortium, and what is our approach? What we've been trying to do is consider One Health approach to reduce the burden of infection and in antimicrobial resistance in children under 5 in urban slum dwellers, and that's the CHIP Consortium. But I'm going to talk to you not just about this work, but other work we've been doing as well that led up to the CHIP work. So just as a reminder, like I said, it's been a very, very long day for all of you, and you know more than me the data that we're going to present. 6 out of 10 infections in humans are transmitted by animals. 75% of emerging human infections are of zoonotic origin. And it costs a huge amount of money, as we're seeing now, not only for people's health and well-being and mortality rates, but also on the long-term impact of their going back to work. We know even with COVID at the moment what the consequences are for people's health, but also on children who, because of the infection that is now surrounding us, have been taken out of school. Some children with disabilities who are not able to have any friend communication, any engagement, no speech therapy. And so it's the secondary consequences of infections we also need to think of, as well as the primary consequences. We all know children under 5 are some of the most vulnerable in the population. And then there's pregnant women and the immunocompromised. Unfortunately, when you package together, you actually end up with a very, very serious situation. The vast number of children that we know under 5 also have other comorbidities in middle-income countries, such as malnutrition. Pregnant women, we'll talk about that in a minute, but they need to stay healthy to give birth to healthy children. And sometimes the most weakest of people are the immunocompromised, who again have a knock-on effect, are going to pick up more and more infections. So mothers are crucial in this whole story. We mustn't forget those in a child's life. I always try and think of mother and children as a package, and this is something I'm sure you all well know, is it's not the child on their own, it's not the mother on their own, but we have to think of them together. The babies spend the first 9 months of their life in utero, where they are at high risk for their development. And the mothers themselves, we know, at high risk as well. They are often the main carer of the household. They're often the one who is earning the money, who are going out to the fields, to the rural areas to work. And they are often the ones who are weaker as well, being deficient of iron or deficient of B12, and are more likely to pick up infections. So we have a gender issue here to consider as well. The impact then on the mother is if she picks up an infection, there is a knock-on effect to her baby. The baby's development starts in utero. Their brain is developing very, very quickly in utero, and so are their bones. And so if the mother's, the food that she's eating isn't clean, if she's going to be infected, has a huge effect on the outcomes for that baby, even before they go into childhood, just at the point of when they are born. Just talked about this as well, that mothers' average time, this is a study that we did in India, and we looked at mothers' time use. And you can see there that mothers were spending some of their time caring for their children, some of their time cooking, some of their time in domestic work, eating and drinking, but a large amount of their time in farming and livestock. Of course, this is contextualized depending on where you live in the country, but this was in the rural area. And even with sleeping, they were often sleeping with the animals, close to the animals, because they were scared of the animals being stolen. So again, they are very, very close to the high infection risk that then could have a knock-on effect to the children that they give birth to. So what about children? Well, the children's brain is growing at a very fast rate in the first 1,000 days. 80 to 85% of brain growth takes place during these first 2 years. So you can see it's a key time, a critical window of when we need to protect children. The child's functional capacity is defined again in the first 1,001 days. And we can see that their neural connections, their brain connections, are forming at a rate of 700 to 1,000 per second. And it's this brain that then creates the foundation for a child's future life, their ability to learn, their ability to function and thrive as an adult. And anything that impacts on that will have a long-term damage for their education and learning and growth and then engagement in civil society. So we must consider how we protect those little brains that are growing so fast from the infections that you've all been talking about today, and what are the risk factors for them through their food that they eat, through the disposal of their stools, through the touching and interaction with the animals that they often live around. We know that I was talking about the brain and the brain's growth, but why is that so important? And I think it's just important to present this to you because sometimes we can think of the animals and the infections and what's happening about that, but actually thinking of the impact of how deeply this impacts on children's lives is something we don't always discuss, that I hope we'll discuss today. The impact is on sensory learning. They need to, their brains, the sensory skills are developed during this very early age. Their language skills, the higher cognitive function, meaning the complex learning, the critical analysis that they develop is again at this very young age. And we know their physical growth and bones. So we need to give the best start to these children in their lives. And one issue, that's why One Health is so important, is because we cannot do this in silos. As paediatricians, I can't do this on my own. As yourselves and people work in the veterinary world, you can't do it on your own. So it's time we need to collaborate, co-develop, come together to try and find solutions to these very, very complex problems. This again just illustrates, please don't worry about the detail in this, but this again tries to show you just really how the brain is developing and how the neural network is developing. Again, a very, very critical window, which is this early age. And often the resources are not put into preventing infections at this early age. The children are born, they're looked after, they're nurtured, but we don't take, as there's not much funding and there's not much effort often put into this critical period. The bones, again, you can see this growth as well. The bones grow until we're 20, but actually it's in the very, very early years of life when the bones are growing fastest. So again, the first 1,000 days are crucial to bone growth. And malnutrition, you'll all have heard about the terrible situations of malnutrition across the world, and this is not just in low middle income countries. In the UK now, we are also seeing children who are malnourished, particularly during these days of COVID, when children are also not getting access to the right sort of food. So this is a problem we share globally and must think about. The problem is that with malnutrition, we get into, again, this cycle with infections. Once a child picks up an infection, they become weak, they have diarrhea, they can't eat, they can't absorb their food, and they get into another cycle. And we can't seem to break that cycle unless we consider the linkages between the food that children eat, how the food is prepared, and the infections and environment that the children live within. So another issue that we're seeing a lot of is that malaria, and I'm sure you know, malaria and malnutrition can coexist together. But often children who are malnourished are not tested for malaria. And I don't think, and it may be coming in, and I know there's a lot of policy talk around this, about should we be screening all children who are malnourished for malaria as well. Symptoms of any zoonotic illness are vague. Children feel tummy pain, they feel tired. Some are born with congenital problems and congenital infections. Some are born with epilepsy and brain problems with development of their brain. But a lot of the time, the symptoms are very, very vague. And yet we don't always test for an underlying zoonotic when children are presented to us. Some areas in India now, I know, and you'll know this better than me, that have brought in programs where we are now testing malaria and malnutrition because they coexist. But this is not extensive throughout India, and it's not extensive throughout the world yet. So we have a policy gap. And this is where, again, with the One Health approach, we need to be working together, not only as clinicians, not only as social behavioural scientists, but also with the policymakers to implement some of these assessments, early interventions that we need to be doing. So as mentioned, we have this cycle where a child may be undernourished first, they then have a reduced immune function, and as I've explained, once you've had a reduced immune function, you're more likely to pick up other infections as well. You then get a prolonged illness because you cannot fight your infection, you lose your appetite, you lose your energy, and you have increased energy requirements, you don't eat, and you go round and round in the cycle again. On top of that, families often seek treatments, antibiotics, other treatments, not always from healthcare professionals, sometimes just frontline Irish workers or other pharmacists in other countries. And then we get into the cycle of antimicrobial resistance as well. So a cycle that we can't seem to break, but we need to find a way to do that. And then what's the long-term consequence of all this? We talked about mortality and morbidity, but also stunting. We know that children who are malnourished due to infection risks are stunted. And we know that when they're stunted, they do have there is a long-term consequence for them, for their future childbirth, mothers who can't easily give birth to children when they grow up, engagement with economy, engagement with other work, and early mortality when they're older as well. So as I've said, first 1,000 days, critically important. And we need to think of modifiable risk factors such as the behaviour, family behaviour, environment in which people live, and social inequalities. And I think we must think of One Health, the One Health and zoonotic infections as an issue around poverty and also an issue around social inequality. Of course, we've talked about people who have pets and keeping their pets healthy and the food that they have, but there is a real social inequality issue here, and something that we really need to grapple with very soon. The problem is for children is that we talked about behaviour, and that's a real passion of mine is thinking about people's behaviour. Why do people do what they do, and how can we intervene, and how can we work with them to change some of these modifiable factors? A top-down approach does not work. A one-size-fits-all does not work. And children particularly are high risk because they're the ones who sleep with the animals, play with the animals, fight with the animals, get bitten by the animals. And so we're going to actually be very, very high risk of picking something up. In addition to that, we know in many places that there's a high level of pollution as well, which also has a link to antimicrobial resistance, but also sometimes attracts lots of rodents, lots of other animals, that then puts the children at risk again. Children bathing in dirty water, children drinking from dirty water. Yes, we have a wash sanitation issue, but there's a bigger, much bigger environmental issue to consider as well. And then, as you will know, often the children will drink the milk straight from the animal, milk that has not been treated, milk that then is infected, and then we get into this whole cycle again. I'm just showing this a little bit of an illustration of that we're doing in England at the moment, because what I'm trying to show is this is a problem across all countries. It's not just across in India or low middle income countries, but here in the UK, we have many families living in informal, what is similar to informal settlements or temporary accommodation, where children are living in small homes, maybe not small as everybody's we know, but small homes where we know there are cockroaches on the floor, we know there are rats in the floor. And these particular pictures were taken by my PhD student, and you can see the chair in the picture there. And the chair was there because a mother had to strap her child into the chair so that the child would not put their foot on the cockroaches on the floor. This is in the UK. The knock-on secondary consequences of that are that these children then cannot develop properly. The child can't crawl on the floor, the child doesn't learn to walk, and there are all these other secondary consequences that often are not discussed together when we're talking about infections in children. So moving on from that, we started a study thinking about malnutrition in India. And we are very aware that lots of studies have been done where the discussions have been around randomized trials for sanitation, and some of them have failed. And we came together as a group where we had people from education, engineering, environment, and health to consider why would some of these interventions failing. And we called this the Panchil project, and it was led in Jaipur, outside Jaipur in Banswara, as a case study for us. And what was clear was that food alone wasn't going to solve the malnutrition problem, but actually, without actually considering all the different infection pathways that we need to consider, we were never going to tackle this problem. But this is a very, very complex issue. Doing a trial on somebody washing their hands or somebody having a toilet versus not having a toilet, it is much more straightforward, but trying to get to the underlying complexity of these infection pathways is much harder. And where we started with this was we started with what we call the Socioecological Model, which many of you may know. And we started thinking about what was the child doing within their very close environment. We then considered what was happening within the community within which they lived. And then we went to think about policies as well. So we took a very structured, layered approach around this issue. We used what we called a settings approach, where we look at what levels do we need to be targeting interventions. So within the household, a lot of interventions are focused and targeted around the mother. However, the grandmother is there who often looks after the child. The grandfather who can bring in infections has touched the animals, knows in. The father, again, who's come into the home. What about in the school? How do we tackle school and the behaviour within school, where again there may be other interactions with animals and infections, and then the wider community and at the policy level as well. So we developed this 8-step approach, which I can go into in more detail at some other time, but it was a very structured 8-step approach about to co-design interventions around behaviour and environmental interventions together with the community, using formative research, policy research, community champions, and then collating all this evidence to try and design a very complex intervention pathway. So this is where we really started, and as you can see, it does look very, very complex. We were thinking, what is the end product? I've talked a bit about malnutrition and infant feeding practices as one of the places where we wanted to target. But just if you look at this next diagram, you can see what the environmental factors were that we were considering at the same time. So child infection risk, food preparation we've talked about over the past few hours. If you don't prepare the food properly, however much food you give to your child, it's not going to solve the problem. Food hygiene, looking at water, thinking about feminization of agriculture, mothers being in the fields, and so mothers bringing infections back, environmental infections. There are so many interlinkages here that unless you consider all of these at different levels, it's really very, very hard to break this problem that we're trying to do. And we can't solve all of this, but we can be cognizant of it and we can consider it. So what I feel is that the best tools in our toolkit were our eyes and our ears. We spent some time first going out, sitting with the families, actually asking them how they lived, understanding their lived environment and understanding their daily practices. In addition to that, we worked with community champions who mapped out the villages and mapped out where the water was, mapped out the different types of water, the boreholes or the wells, to actually think, where were people getting their water? How long did it take to store the water? Where were the animals living? Were the animals living in the household? Were they living further away? So what was that interaction between the animals as well? We brought together the academic teams, the families, the community to then co-design interventions together. And this is the sort of thing you'll have all seen as well, but unless we see it with our own eyes, sometimes in research, we don't always take consideration of it. So we are building toilets, we're encouraging sanitation, we're encouraging washing. One household, the soap was locked away. They had soap, but the soap was locked away. This household here, animals tried to prevent open defecation, but the children were walking over a whole area where there was excretions from the animals, and they had bare feet as they were walking over this. We also considered where schools could come into this. So who can we target? How can we bring about some interventions? And we looked at the schools as a hub, and parents very keen that schools could be a place to educate mothers, because it has been shown that if you have increased literacy rates, then some of the there is a reduction in zoonotic infections because there is a better understanding of what needs to be done. There is opportunities to set up hand washing stations, and children themselves are key agents. They are change agents themselves. If we teach the young children what to do effectively, we can then take those messages back home as well. So this moved us on to thinking, well, we've tried to spend a lot of time. I mean, this was a three-year piece of work that I'm telling you about in 10 minutes, but the work in the rural villages made us really think about how do we get to the bottom of this? How do we actually find out in more detail what the different pathways are, and how can we spend time with the communities to actually understand how they live, and then how we can approach solving some of these problems. So we then set up this CHIP consortium, which brought together experts in veterinary science, experts in clinical science, experts in epidemiology, public health, and third sector organisations as well. So I'm really giving this on behalf of my colleagues. So we've been working with people in Tokyo, Hong Kong, America, India, and Jakarta in Indonesia, and Chile as well. So this is three countries we particularly focused on are Chile, India, and Jakarta so far. But as I reflect, we were very, very concerned that there are lots and lots of failures in the current WASH interventions. Not that they're going to find that there's a solution, but we were finding that there were some critical pathways being missed. And so we wanted to try and start at the beginning, really try and unravel some of this. In addition, you will have seen this Liebow's One Health research approach. What was very interesting is it's a very helpful approach to One Health, but there was very little in there about co-development, behavioral science, how to change people's behavior given their context and their socio-cultural factors that influence people's lives. So we wanted to really take a grip of that a little bit more. And we're also aware that we're in a world where on one hand we have a huge number of middle-class people who are living in much nicer environments, but still contributing to the pollution that other children are living in. And we have an increasing problem with antimicrobial resistance due to easy access to medications. But on the other hand, we have children who have skin infections that's underreported because children are jumping in and bathing in pools of water where they're at high risk. Again, we were aware that we have these different increasing research papers talking about antimicrobial resistance, and we really have a time bomb on our hands. We'll rush through this. So we felt that there was no time and we needed to get going, and we got some initial funding to start this collaboration together. And thank you to all the people who are working with this consortium. So we started thinking of using a One Health and a citizen science approach. And the citizen science approach was an approach where we wanted the community to actually start collecting data. We haven't got to this part yet, but collecting data to provide us with information from the environment that they live in. And we set up, again, this very, very complex conceptual framework, which is a bit like the one I showed you on malnutrition. You get the picture that I like these complex pictures, only because we can then see what the human factors are, what the animal factors are, and what the environmental factors are that then we need to think of and look at the interlinkages between all of these factors and start addressing some of these pathways. And that then helps us to consider the different transmission of zoonotic infections, from aerosol droplets to direct infections, especially for children, fomite, oral and vector. I won't go into this as this is your specialty and your expertise area. But again, when we're designing our interventions, we have to think of awareness. How do we make people aware of this problem? How do we then give them the skills to be able to tackle these problems? There's no point in raising people's awareness, but not then giving them the skills to tackle the problems. How do we consider, yes, hand washing practices, but they have to have the resources to buy the soap. They have to be able to afford to buy the soap, and they have to understand the benefits of that. We talked about cohabitation practices. Well, it was very clear from some of the families that we met that the children were sleeping with the animals out of comfort, out of feeling that they were pets, but that also the families were living with their animals to protect them because they felt that they would, as I mentioned, they would be stolen or somebody would take their animals. Now, it's easy for us to say, well, people shouldn't sleep together because of risk of infection. But when people are weighing up the risks and benefits for themselves, well, livelihood, making sure you don't lose your animals, comes above the risk of infection. And then also we have to link it to health systems approach as well. If people have got infections, if they are ill, even the skin infections I just talked about, the children get, how do they access care? Where do they access care? And if we don't also think of that and the training and capacity building of the professionals, we're going to end up in a system where we have increased microbial resistance because of inappropriate treatments being offered to people. And of course, the risk of death and a risk of morbidities as well. And another big area is linking in with the education system. I think people often forget the education system, but as I've mentioned, many of these children have learning difficulties because of the impact of the infection on their brain growth. And these children are then not supported effectively within the school environment. So it's not just a health issue. We talk about One Health. Actually, it's not just a health issue. It's an environmental issue. It's an education issue. It's a well-being issue. It's a poverty, and it's an inequality issue. So in CHIP, like we've mentioned, we chose India as one of the countries that we were going to be working in, and you know all the data, so I won't go into that. We chose Indonesia as well. There's many slum dwellings in Indonesia that has children, again, living in some very difficult environments. And we chose Chile, and Chile has been coming out of, it's not a low-income country anymore, but it has a very different context of temporary settlements than India or Jakarta, so we wanted to compare what was happening in different countries. The key research questions for this work was, what are the One Health infection pathways relevant to these children? What's the social geography and community structure of the slums? What's the acceptability of sampling procedures? So again, when we think about research and we think about, doing tests on children, some of the sampling procedures may not be acceptable, either because it's painful or either because from a cultural or religious perspective, it may not be acceptable, such as cutting the hair or asking for hair specimens. And what's the feasibility of using the mapping exercises and GS codes? So we spent a lot of time training community champions because we can't go into the community directly. We won't get the right answers. People will withhold information from us. People do not tell us always the truth if, as an academic researcher from the outside, we go to sit with them. We then used our eyes, we walked around, we saw the animals, we saw how people were living, we saw the soap locked in cupboards, and we saw what the potential risk infection pathways were that could impact on the child. We saw dirty cloths being used to clean plates, which then has, and vegetables not being washed, but being prepared and given to young babies. We used social mapping, so we looked at where the families were living, looked at what the environment was that they were living within as well. And we mapped out the different houses and where the streams were, where the rivers were, where the pets were, where the corner shops were. And we did quite a lot of work with the families to look at the feasibility of taking samples from them. So if we were going to come back to do stool sampling or nasal sampling or air quality sampling or urine samples, would this be feasible and would the families allow it? We were quite nervous about whether this would be possible, but very strong feedback from the families was that as long as we were doing something for the well-being of their children, they were happy to provide the samples. So where do we go from here? Well, next, what we want to do, and we are doing, is we are writing bids at the moment for further work in Jakarta, particularly in Indonesia, and currently working on towards a project as well in Jaipur, in the slums as well, to look at infection control. And we're also trying to look at ways of using digital platforms and citizen science approaches to collect data from this early stages yet. So on behalf of us all, on behalf of the CHIP consortium, what I'd like to say is it's a very, very complex problem. We look at things in silos, we look at things in segments, but we need to work together. We need to work with our citizens and our community. It's not a medical issue, it's not a science issue, it's not an academic issue. From my perspective, it's all of those, but it's also a social issue, and these children deserve more, and we need to support them to achieve more, really. The CHIP consortium felt that what we're doing is we're working with these deprived populations, thinking about this in a holistic way, and this is why everybody wanted to come together to try and jointly hold hands and make a difference for the world. If you need any more information, you can contact us through these different mechanisms, platforms. I'm not very good at technology, as you saw, but you can come through this through these different mechanisms. And just to thank you to all my colleagues who helped me with the slides and all the work we've been doing so far. Thank you.